An introduction to critical care, presented by me, your host, Pat Nelligan. When we examine a patient in the ICU, we'll often identify abnormalities. For example, reduced air entry in the lung bases, some crackles, some wheeze, maybe some bronchial breathing. But to confirm or disconfirm that there is a diagnosis present, for example, consolidation, pulmonary edema, pneumothorax, we really do have to image the chest intermittently at least. This is usually done by a portable bedside chest x-ray in the ICU, but sometimes we send patients down to the radiology department to have a CT of the thorax. Chest imaging in critical care, part 3, diseases. Welcome back. In the previous tutorial, we discussed the imaging of the patient's chest with a chest x-ray to look at hardware and its positioning and where it should be positioned and where it should not be positioned. And I discussed endotracheal tubes, central lines, pulmonary artery catheters, intra-aortic balloon pumps, and chest drains. In this tutorial, I will discuss diseases of the lungs and the thorax. We'll look at the pleura and the mediastinum, and we look at the lung parenchyma. Let's start with the pleura, mediastinum, and more. Val is 28 and has presented with hypoxic respiratory failure and treated with high flow. Look carefully at the picture. What do you think? Well, the mediastinum is the central compartment of the thoracic cavity, and it contains the heart, the great vessels, the trachea, the esophagus, etc. Pneumomediastinum, or mediastinal emphysema, is where air is in the mediastinum. It shouldn't be there, although you do expect to see it after cardiac surgery. The signs on chest x-ray are evidence of mediastinal emphysema, meaning that the various components of the mediastinum are outlined with black lines, for example, the heart and great vessels. There is radiolucency around them. There is also a continuous diaphragm sign where there is separation of the diaphragm from the heart. Sometimes there are rings around the arteries caused by air, but it's not apparent in this picture. This particular case was a patient who had pneumomediastinum following COVID-19. The causes of pneumomediastinum commonly are chest trauma, esophageal rupture, barotrauma associated with mechanical ventilation, ruptured alveoli that you see, for example, with COPD, and gas-producing infections. Have a look at this picture. What do you see? Well, you'll notice there is really extensive subcutaneous emphysema all over the place, and there is a pneumothorax also on the left-hand side. The outline of the heart is really easy to see. It's like there's a lasso around it. So this is a patient who's had an esophageal perforation with pneumomediastinum and bilateral pneumothoraxes. The same patient is seen now with bilateral chest tubes in place. The lungs have inflated, but there is really extensive subcutaneous emphysema. What's going on in this particular picture? This is the typical appearance of a pleural effusion on chest x-ray. Typically, you see blunting of the costophrenic angle. You see a meniscus sign. That's curved lines that rise up the chest wall, creating a concave upward appearance. The opacity is homogeneous, and there is mediastinal shift away from the effusion. If you lie the patient on their side in the decubitus position, the fluid moves with gravity, and so it layers along the dependent area. Pleural effusions are typically transudates or exudate. A transudate is the result of increased pulmonary hydrostatic pressure or reduced oncotic pressure. An exudate is caused by local inflammation and increased vascular permeability. Typically, transudates are caused by heart failure or fluid overload. We see that a lot in the ICU. We see it with cirrhosis and hypoalbuminemia for any cause, particularly nephrotic syndrome. The most common cause of exudates that we see in our practice, of course, is infections, pneumonia. We also see exudative pleural effusions with trauma and post-op cardiac surgery, And then coming in from the community, it's seen with various different cancers: lung cancer, breast cancer, lymphoma, metastatic cancers, inflammatory diseases such as rheumatoid arthritis or pancreatitis. In this picture, can you see any abnormality? There are bilateral, small pleural effusions demonstrating the meniscus sign. This is a patient who presented with shortness of breath and a large pleural effusion. The effusion has been drained, revealing a large hilar mass. In this case, the pleural effusion was caused by lung cancer. This is a massive left-sided pleural effusion. How do I know that this isn't just pure atelectasis of the left lung? I know this because the mediastinum has been shifted towards the right. Remember, atelectasis, everything moves towards the collapse. With pleural effusions and pneumothoraxes, everything gets pushed away. Dennis is 72 and he presents with acute abdominal pain and shortness of breath. Do you see any abnormalities on this chest X-ray? The abnormality is here, and this is known as pneumoperitoneum. Pneumoperitoneum is the presence of air in the peritoneal cavity. The most characteristic sign on chest X-ray is free air under the diaphragm. Remember that air always rises to the top, so if it is in the abdomen, it rises up to the diaphragmatic surface if the patient is erect and it gets stuck there. However, if the patient is lying flat, there may be a cupola sign, that is a dome-shaped radiolucency below the central part of the diaphragm. Pneumoperitoneum is seen with acute abdominal pain or an incidental finding. With acute abdominal pain, we are thinking of a perforation in the gastrointestinal tract, and it is not a specific perforation. Yes, it's commonly seen with duodenal ulcers perforating, but you'll see it with a perforated diverticulum or a large bowel perforation, and it's sometimes seen with trauma. It's also not infrequently an incidental finding. If a patient has had abdominal surgery, air will be trapped in the abdomen afterwards. Likewise, patients on peritoneal dialysis will always have air under their diaphragm. Occasionally, you do see it with mechanical ventilation where there is an air leak from the thoracic to the abdominal cavity. This is pneumoperitoneum after a bowel perforation during colonoscopy. What's going on here? I think it's fair to say that this cardiac silhouette looks really strange. It's enlarged and it's pretty massive. It looks like a boot. This may be due to cardiomegaly or pericardial effusion. Cardiomegaly is associated with a cardiothoracic ratio, that's the width of the heart versus the width of the chest, of more than 50% in a PA film. In cardiomegaly, you often see signs of heart failure, such as pulmonary edema, and the heart border is well defined. In this case, the heart border is globular, with smooth contours, and there is no evidence of pulmonary congestion. So I think that this is a pericardial effusion. Pericardial effusions are not seen commonly in critical care, and if you do see it, you need to think about an inflammatory cause. That's pericarditis caused by infection, inflammation, autoimmune disease, etc. But we also see it after cardiac surgery, trauma, cancer, kidney failure, that's uremia, after myocardial infarction known as Dressler syndrome, or hypothyroidism. Have a look at the next picture. What do you see? In this picture, the heart is really big, isn't it? It's huge, but again, got to be careful. There's a bit of projection. It's a semi-erect AP film. However, the sign I want you to concentrate on is bang in the middle of this picture, right here, where you have splaying of the carina, and that's caused by an enlarged left atrium. Roy is post-op a hip replacement and he complains of dyspnea and chest pain. In that setting, one diagnosis rules all, and that's an acute pulmonary embolism. This is a CT pulmonary angiogram demonstrating a pulmonary embolism in the main pulmonary artery. Now, this is something that radiologists do to make this diagnosis. This is not the job of the ICU doctor. The ICU doctor needs to recognize there may be a pulmonary embolism and order a CT pulmonary angiogram. Chest x-ray is just not good enough. You're unlikely to see it. In this situation, this patient will need high-dose anticoagulation. Pulmonary embolism is seen with deep venous thrombosis. The cause of deep venous thrombosis is usually some form of hypercoagulable disorder or prolonged immobility. For example, following surgery, particularly pelvic surgery. We see it with cancer, with obesity, with trauma, with hormonal therapy, for example, the oral contraceptive pill or pregnancy, and then in patients with coagulation disorders that make them thrombogenic. Now, let's move on to the lungs. Trish is 59 and she presents with fever and dyspnea. In this situation, you can see patchy opacities scattered throughout the lung fields that do not respect any lung or lobar boundaries. This is traditionally known as bronchopneumonia. John is 70 and he presents to the emergency department with shortness of breath. Let's look at a CT of the thorax. This is the upper zones of the lungs, principally the upper lobes. And you'll see as you advance through the lungs that there is increasing opacities throughout the dorsal segments of his lung fields. And he has dense bilateral bibasal consolidation. And this is the typical pattern that we see with many of our patients who present with community-acquired pneumonias. The reason why I'm showing you these images is because it is clear on the CT of John's thorax that his infiltrates are posterior and dorsal in the lungs with relative sparing of the anterior apical segments. However, if you were to look at John's chest x-ray, it would appear that he has homogeneous infiltrates scattered throughout the lung fields. Natalie is 32 years old and she presents to the emergency department with shortness of breath and wheeze. This was her chest x-ray at the time. She settled down with bronchodilators and some antibiotics and we didn't see her for a month. But 4 weeks later, she presented with dyspnea. And this is what her chest x-ray looks like. It's very different. There's one clear finding. Can you see it? There is right upper lobe pneumonia, really well delineated because you can see the oblique fissure. Let's look at the CT of her thorax, and you can see on the CT that her right upper lobe is densely consolidated, but as you pass through the lung fields, there is very little consolidation in her basis. So this is a right upper lobe pneumonia. Roger is 72 years old, he's a heavy smoker, and he presents with dyspnea and a fever. This is his chest x-ray. You can see that he has lobar pneumonia with consolidation that impacts the whole lobe of the lung, that's the left lower lobe. The opacity is relatively homogeneous in one lobe with well-defined borders and air bronchograms. This particular diagnosis was pneumococcal lobar pneumonia. He has now been intubated, and there are two things that are wrong here. Can you identify them? The first is that he has an NG tube inserted into a bronchus. The second is that his endotracheal tube is a little bit high and it needs to be advanced. On the CT of his thorax, you can see that he has bullous emphysema. Later, you see that the pneumonia has cleared, but there is a new abnormality. Can you spot it? there is a left-sided pneumothorax. Now he has a chest drain and a tracheostomy. Ray is 72 and presents with acute shortness of breath on the ward. Can you see the abnormality here? There is a right middle lobe infiltrate, and the likely diagnosis here is that Ray has aspiration pneumonitis. This is another case of dense infiltrates in the lower zones of the lungs with apical sparing. This is typical of bilateral aspiration pneumonitis. Maria is 62 and she presents with acute shortness of breath and chest pain. This is her chest x-ray. What do you think? This is acute pulmonary edema. Now you can't comment really on the size of the heart because this is a PA film, but the heart looks pretty big. Note that there are bilateral opacities that spread out from the hyla like wings, and then they terminate in the extremities of the lungs. This is due to venous hypertension and fluid accumulation. Len is 68. He's short of breath in the ED and has a loud systolic murmur, likely severe mitral regurgitation. This is his chest x-ray. Now in this case, there is ground glass alveolar edema. So lots of the alveoli have been flooded with fluid. Note also that there are these horizontal lines in the lower zones of the lungs. These are known as curly B lines, and they are indicative of interstitial edema. Len goes for a mitral valve replacement, and this is his post-operative chest x-ray. Can you identify the lines in the tubes? So there are a couple of central lines. There's an endotracheal tube, there's the sternal wires, there's a couple of chest drains. There's one other line that you need to take note of, and that's this. The intra-aortic balloon pump. 4 weeks later, Len has a permanent pacemaker and a difficult to see tracheostomy. Phil is 76 with severe dyspnea and he's on the ward, and this is his chest x-ray. The way we would describe this x-ray is bilateral infiltrates in the lower zones of his lungs. This is not really diagnostic of anything. We always assume in this setting that the problem is fluid overload, and we give the patient non-invasive ventilation or CPAP and diuresis. You can see that the patient is now deteriorated, and there are bilateral lung opacities, especially in the left lung, with only the apex being spared. Small pleural effusions are likely present. The patient has now been intubated and has a central line. What do you think of the position of the line and the endotracheal tube? I think they're a bit far in. Brendan is 50 and he has been short of breath for several days, and now he's in extremis. He is rapid shallow breathing and has hypoxic respiratory failure. You can see that he has infiltrates spread throughout his lung fields. They're everywhere, with a little bit of apical sparing, but infiltrates everywhere. There's a relatively normal heart size. So this is likely to be acute non-cardiogenic pulmonary edema, otherwise known as acute respiratory distress syndrome. Note also that the endotracheal tube is a little bit far in. ARDS, ARDS, acute respiratory distress syndrome, is defined as an acute lung injury of less than 1 week duration. There must be bilateral opacities on chest X-ray or CT, and there is usually pulmonary edema that is non-cardiogenic in origin. Most importantly, there must be an oxygenation defect with a PaO2 FiO2 ratio of lower than 200 in millimeters of mercury. Now that cannot have been caused by atelectasis, so in this version, the Berlin version of the ARDS definition, the patient must have had CPAP or equivalent of 5 centimeters of water. Usually with atelectasis, that will recover with some CPAP or recruitment maneuver. In terms of the causes of ARDS, there are essentially two different ways the lungs get injured. One is a direct injury to the lungs, and the other is an indirect injury to the lung. The indirect injury is caused by a capillary leak syndrome, damage to the alveolar capillary interface. The direct injury is usually caused by pneumonia. That's an infection, either bacterial or viral, gastropulmonary aspiration, gas or steam or heat inhalation, and water inhalation or drowning. In terms of the indirect lung injuries, they're usually caused by systemic sepsis, gram-negative or gram-positive, or some form of systemic inflammatory disease like pancreatitis, where there's activation of inflammation around the body causing collateral damage to the lungs, or trauma, which is a multifactorial problem. How do I know that this is ARDS versus acute cardiogenic pulmonary edema? Remember, with cardiogenic pulmonary edema, you're looking at hydrostatic pressure problems. So there is venous hypertension and there's upper lobe venous diversion, hence the bat wings in the picture that I've already shown you on the left. There is peripheral sparing in that picture. In this case, on the right, the lung fields are extensively diseased and there's fluffy infiltrates throughout. So that's typical of ARDS. This is the case of a patient who presented with flu-like symptoms and then rapidly developed multi-organ failure and purpura fulminans and had severe systemic sepsis with Staph aureus. The CT of her thorax revealed extensive bilateral infiltrates throughout the lungs, with most of the infiltrates in the posterior dorsal segments, with relative sparing of the apices of the lungs, the anterior apical segments. This is her day 2 picture. Note that a large catheter has been placed for dialysis. That's a VAS cath. At day 10, you can see that the patient has had a tracheostomy. The lungs look clearer, but you can see multiple cavitations throughout. This is typical of staphylococcal pneumonia. This CT scan was done a couple of days later, and again, huge layering, and there's loads of small cavitations. Now, a question you might be asking at this stage is, what about John? Do you remember John a few minutes ago who had community-acquired pneumonia? And I described pretty similar findings. And I said, well, this is bronchopneumonia. Why is it not ARDS? But of course, it can be ARDS because most of the patients we see with acute respiratory distress syndrome these days have it as a result of community-acquired pneumonia. And ARDS may be a disease that's caused by a direct infection or injury to the lungs caused by an infection, or it may be caused by an infection distal to the lungs or an injury distal to the lungs where cytotoxic material is transmitted to the lungs and damages the capillary alveolar interface. Because ARDS is a fairly nebulous clinical syndrome, what makes this ARDS and not just pneumonia is the degree of hypoxemia. The PaO2 divided by FiO2 ratio has to be lower than 200 to be ARDS. What's going on here? Well, this patient also has extensive bilateral infiltrates on chest X-ray. The patient also has a central line placed, possibly just a little bit too far in. Now, this patient presented in January 2021. So this was ARDS secondary to COVID pneumonitis. With COVID, we saw an unusual pattern of ARDS where the extremities of the lungs were more affected than the central zones, and this was the typical CT that we saw of the thorax. You can see at this level of the chest CT that there are dense opacities in the bases, particularly the left base, that may well be an empyema, but also note these bullae that developed. This is evidence of barotrauma, and not long afterwards the patient developed a very large loculated left-sided pneumothorax. And that's what it looked like on the chest x-ray. Note the extensive subcutaneous emphysema. By mid-February, this is what the chest x-ray looked like. There were bilateral chest drains. The patient also developed a hepatic abscess, and that drain on the right side is going into a collection in the liver. This is what it looked like in mid-March. And then by the summer, the chest x-ray was almost normal. And this was typical of patients that we saw during the COVID pandemic, and we still see patients with ARDS that behave this way. I'll point out that all of the examples that I've shown you in this tutorial are from patients who survived who gave me permission to use their images. Helen is a 45-year-old woman who presented with acute shortness of breath, and this is her chest x-ray. This is another situation where we have bilateral fluffy infiltrates throughout the lung zones, without that characteristic alveolar edema picture. And when you see this picture, you must consider pneumocystis pneumonitis. The patient had a history of partially treated HIV, but any patient with a history of immunosuppression, such as lymphoma or leukemia, may have this PJP pneumonitis. This is the typical chest x-ray and CT findings of PJP pneumonitis. Note the honeycomb appearance of the lungs. With correct treatment, these patients may do reasonably well. Let's review this tutorial. In this tutorial, we looked at diagnostic chest imaging in critical care. I started off with a discussion about anomalies of the mediastinum, particularly mediastinal air, and of course subdiaphragmatic air with pneumoperitoneum. We then looked at pneumonias, including aspiration, pleural and pericardial effusions, pulmonary edema, ARDS, and PJP pneumonitis. I hope you enjoyed this series and follow the subsequent tutorials. I hope you're enjoying this series on Introduction to Critical Care, and I've covered quite a lot of the basics of critical care over this course so far. If you're enjoying the tutorials, please subscribe on YouTube at CCM Tutorials or follow me at my blog ccmtutorials.org. Introduce me to a few friends so I can grow my subscriber base. Leave me some comments and some likes. I'll see you soon.